This is Stephen Todman, Assistant Professor of Pediatric Cardiology at LSU in Shreveport, and today we're going to discuss Lyme disease as
Our
part
objectives
of the
are from the
ABP content outlined for pediatrics, and they are to understand the epidemiology of Borrelia burgdorferi, to recognize the clinical features associated with Borrelia burgdorferi infection, to plan the appropriate laboratory evaluation for Borrelia burgdorferi infection, and finally, to plan appropriate management for a patient with Borrelia burgdorferi infection. Now let's turn to the epidemiology and ecology of Lyme disease. It's the most common vector-borne disease in the United States, and it's caused by the spirochete Borrelia burgdorferi sensu stricto, and it's usually abbreviated to Borrelia burgdorferi. It's transmitted by hard-bodied ticks, including Ixodes scapularis, which is the black-legged tick, also commonly called a deer tick in the East and Midwest. And on the Pacific coast, the species is Ixodes pacificus, also known as the western black-legged tick. Here we have a picture of the enemy. The scale is in centimeters, and we see from left to right the adult female, the adult male, the nymph, and the larva. Now, looking at the typical zones of infection, it's important to know that most cases occur in New England, the Mid-Atlantic states, Wisconsin, and Minnesota. However, less frequently, you can see it on the Pacific coast, Northern California, and Oregon. The number of reported cases have increased as of late to about 30,000 per year, and the incidence is highest in children from 5 to 10 years of age. People with exposure to tick-infested fields, yards, or woodlands in endemic areas are at increased risk of developing Lyme disease. Here we see a map from the CDC of the reported cases of Lyme disease, and we can see in dark blue the increased prevalence of Lyme disease. Ixodes ticks have a 2-year, 3-stage life cycle. The larvae hatch in the early summer and are not infected with Borrelia burgdorferi. The tick can become infected at any stage of its life cycle by feeding on a host that is a natural reservoir for Borrelia burgdorferi, like chipmunks or white-footed mice. Generally, to transmit the infection, the infected nymphal tick must feed for greater than 36 to 48 hours, and the infected adult tick has to feed greater than 72 hours. That being the case, in most instances where a tick bite is recognized, the tick is fed for less than 48 hours, which in part explains the low risk of Lyme disease after a recognized tick bite in endemic areas. Turning towards the clinical aspects of Lyme disease is classified into stages. There's early localized disease, early disseminated disease, and late disease. Erythema migrans is the manifestation of early localized disease, and it appears at the site of the tick bite 3 to 30 days, most commonly 7 to 14 days later. The skin rash itself begins as a red macule or papule and expands for days to weeks to form an erythematous lesion that can grow greater than a foot in diameter. In about 2/3 of the time, the rash is uniformly erythematous, or it has enhanced central erythema. The rash can appear as a bullseye lesion, and occasionally it can have a vesicular or necrotic area in the center. Here we see 2 images of Erythema migrans. Some important points to know about the rash is that it's often asymptomatic. It can be pruritic or painful, and it can be associated by systemic symptoms like fatigue, malaise, headache, stiff neck, myalgia, or arthralgia. Multiple erythema migrans is the most common manifestation of early disseminated Lyme disease. It usually appears 1 to 4 weeks after infection and consists of multiple annular erythematous lesions. Here's another image of multiple erythema migrans. Turning to symptoms, erythema migrans, whether single or multiple, occurs in about 90% of patients with Lyme disease. Other common manifestations of early disseminated Lyme disease include cranial nerve palsies, particularly facial nerve palsy, and meningitis. Systemic symptoms like fever, myalgia, arthralgia, headache, or fatigue are common in this stage of Lyme disease. Carditis usually presents with a prolonged PR interval on EKG or, rarely, complete heart block, which in some cases may result in syncope. Arthritis is the most common manifestation of late Lyme disease, and it occurs weeks to months after the initial infection. It's usually monoarticular, but it can also be oligoarticular. It primarily affects the large joints, like the knee, and although the joint is typically swollen and somewhat tender, the severe, intense tenderness associated with acute septic arthritis usually is not present. Turning towards the differential diagnosis, it's important to know that the rash initially may be confused with entities like nummular eczema, granuloma annulare, insect bites, ringworm, or cellulitis. The rapid and prolonged expansion of Erythema migrans, if it's untreated, can help to distinguish it from the above conditions. The sensitivity of culture for Borrelia burgdorferi is only fair, and special media are required, and this test takes weeks before a result is available. Concentrations of the bacteria in the blood and cerebral spinal fluid are low, and this results in poor sensitivity of PCR assays for these samples. So how do we make the diagnosis? Confirmation by lab usually is from antibodies to Borrelia burgdorferi in the serum. Official recommendations from the Second National Conference on Serologic Diagnosis of Lyme Disease and from the CDC are that clinicians should use a two-tier procedure when ordering antibody tests for Lyme disease. A sensitive screening test, usually ELISA, should be performed, and if that result is positive or equivocal, a Western immunoblot is performed to confirm the specificity of the results. Treatment consists of antibiotics and possibly NSAIDs if they're needed. IV ceftriaxone is often used for Lyme meningitis, but doxycycline is preferred because of the excellent CNS penetration. However, doxycycline is not recommended for children less than 8 years of age because it can cause permanent teeth discoloration. Prevention is multifaceted and it involves reducing the risk of these tick bites. Application of pesticides to residential properties can be used. Additionally, tick and insect repellents that contain DEET can be helpful. It's important to know that the use of products with concentrations of DEET greater than 30% is not necessary, and it increases the risk of adverse effects. Teaching adults to inspect themselves and their children's bodies and clothing daily after possible tick exposure is important. And the attached tick should be grasped with the fine-tipped tweezers as close to the skin as possible and removed by gently pulling the tick straight out. If some of the mouth parts remain embedded in the skin, they should be left alone because they are usually extruded at some point soon afterwards, and there is a risk of trauma that results when the parent is continuing to try to remove the tick. Additionally, no vaccine for Lyme disease is currently available. There's excellent long-term prognosis if the patient with Lyme disease is treated appropriately, regardless of the stage of illness. Nonspecific symptoms like fatigue, arthralgia, or myalgia can persist for weeks, even in patients with early Lyme disease who are treated successfully, and their presence is not an indication for additional treatment with antimicrobials. I'll now provide questions for review, and best of luck on the boards.